All right, today we're going to talk through our newborn head to toe assessment. So, first and foremost, we need to focus on baby safety because baby safety is paramount when we do anything with baby. So, I want to show you what we want to see when we're looking at a bassinet. We have baby in the bassinet, and all we have is a bulb syringe because we need that in case baby plugs up with fluid and we need to clear that out. But we don't want any stuffed animals in here. We don't want any signs with babies' names on it or anything. If parents do that for pictures, we take it right out as soon as the picture's done because we don't want it to fall and hit the baby. So we have our gloves on, we have our bulb syringe, and baby is safe in the four walls of the bassinet. Then we want to verify that this is the right baby. Baby's wristband matches mom's wristband. So we would check that. They're usually on baby's legs. So we would check that out and match it with mom's. Then we are going to just look at the baby. How is baby acting? What's the baby's level of consciousness? Is the baby sleeping? Is the baby awake but quiet? We call that quiet alert. Is the baby active alert and actively looking around, moving extremities, or is the baby crying? And then we want to do a pain assessment before touching baby because we could make baby cry and upset, and that could throw our pain assessment off. So we're going to be looking at assessing for the flack, looking at the baby's face and legs and arms and cry and the consolability of the baby. And then we want to auscultate. Before anything else, we need to listen to baby's heart and lungs because we want to actually hear the sounds we're looking for and be able to count before making baby super agitated. So we are going to take our stethoscope. You can see this is a neonatal stethoscope. Your regular size stethoscope will be okay, but we're going to use this one for the demonstration. We're going to listen for the heart rate for a full minute. We're also going to listen to the respiratory rate for a full minute because babies can breathe sporadically, some fast breaths, some slower breaths, and as well as baby's heart rate beats very fast. So you're looking at a rate between 110 and 160. So we're going to just gently unswaddle the baby. We don't want to disturb too much. So we're going to listen for my full minute at the heart. I'm going to listen to lung sounds. And then we're going to listen for a full minute for respiratory sounds. So we've heard lung sounds on both sides, and then we get our rate either side. It doesn't matter. You're going to listen to that for a full minute. And then that way you know you have heard those sounds and baby hasn't disturbed your counting with crying. Next, we're going to start at the head and work our way down. So we can even just re-swaddle baby up and we can just move to the head. We're going to take the hat off. So I've taken off the hat and then I'm going to assess the head. I'm looking at suture lines and fontanelles. Now, this baby, this simulator baby, doesn't have suture lines or fontanelles to show you, but we're going to talk through them. So the coronal suture is what I call the headband line. So you'll see that a coronal suture will be present here from ear to ear. It looks like the baby's wearing a headband. And then the sagittal suture is more of a mohawk line. So it'll run through the fontanelles and you will see that sagittal suture kind of like a mohawk down the middle of baby's head. And then we're looking for molding. So did baby spend a little bit of time in that birth canal and the baby's head is going to be, see how this baby is perfectly round. This is not the normal. You're going to see some molding where that baby's head is a little bit more of a cone shaped. And then we're looking at our anterior and posterior fontanelles. So our anterior is a diamond shaped fontanelle. We say diamonds are worn in the front. And then, so diamond in the front, and then the triangle fontanelle, posterior fontanelle is going to be back here. We are just assessing that by rubbing our fingers gently and lightly over them. We don't want them to be bubbled up, and we don't want them to be deeply kind of engraved in baby's head. They should just be palpable. So then we're going to move on to the eyes. I have my pen light here. I just want to make sure that baby's pupils are going to dilate. I don't want you to spend a lot of time here. You don't want to agitate the baby. They're very sensitive to light. So we're going to dim the light in the room. And then we're going to be able to look at baby's eyes. We are not forcing baby's eyes open. Babies should just open their eyes naturally in the dimmed light, and we're just taking our pen light and we're looking for pupillary reaction and symmetry on both sides. And then we can turn our light back on. Looking at ears. So our ears at baseline should line up with the outer canthus of our eyes. And this is where you're assessing for, could this baby have low set ears, meaning the ears have formed lower set than the outer canthus of the eye. And we should have two ears, so one on the left and one on the right. Then the nose, babies are obligate nose breathers. So all you're doing is just gently occluding one side at a time, just to make sure that both sides of their nose are clear and working. Babies with that were born via C-section may be more congested than other babies because they didn't have time to get all the extra fluid squeezed out of them. You may also see that these babies sneeze a lot more because they're just trying to clear the fluid out. Then looking at the mouth, we're going to be assessing the palate for intactness. So I have my gloves on. I'm just going to gently put my finger in the baby's mouth, and I'm feeling the upper palate. I want to make sure that we're not missing a cleft palate, meaning a hole between the baby's mouth and the baby's nose. And then we're also going to be assessing for the sucking reflex here. So you're going to, by inserting a finger in the baby's mouth, the baby is going to suck on your finger, and that's the sucking reflex would be present. And then the rooting reflex is if you just gently stroke the cheek, the baby will turn its head towards that side that you've stroked. That's called the rooting reflex. And then looking at the neck, we're checking for webbing. So when you look at a neck, you should see that it goes straight down and then across into the shoulders. We don't want to see webbing where like it more forms a triangle versus a 90-degree angle. Then the chest. Now we can uncover baby. We don't want to make baby cold, so we just kind of do this in steps and processes. We're looking at the baby's chest. We're checking for discoloration. What does the color of the baby's chest look like? Do we see any blues or any purples or anything like that? And then we're looking at the xiphoid process. We're going to look at the bottom tip of the sternum, and we're just here looking at, is the baby having retractions? Could this baby be having difficulty breathing that we weren't catching before? So we're going to just check this area out here. Then looking at the arms should be in a flexed position, and the baby has good muscle tone. And then we want to count the fingers. So every baby should have 5 fingers on each side. If we notice that there is more than 5 fingers, that is an abnormal assessment, and we would want to note that. And then we're also going to check the palmar grasp here. So the palmar grasp is another newborn reflex. And by putting my finger in through the baby's fingers, the baby should close its fingers on my finger, just like this. Then we're going to move to the legs. So we're just looking at this baby's legs. So we're going to count the toes. Again, 5 toes on each side with a total of 10 toes. Extra toes, we call that polydactyly. We look at the plantar grasp. So I'm going to spin baby around here just for camera effects. So the plantar grasp is when I put my finger here at the bottom of the toes, and the baby's toes should curl around my finger. And then the Babinski side, if you brush from the bottom sole upward, the toes should fan out. And that is also another newborn reflex. We're also looking at newborn leg length and making sure that these legs are symmetrical and one is not longer than the other. Then moving into GU, we're talking about genitourinary, we're looking at the diaper. So do we see a dark amber color in the diaper? Do we see any crystals in the diaper? Um, do we we're going to educate if we do see crystals, they're uric acid crystals, and that would be a point of education for the parents that can be completely normal for babies' first urines. And then looking at the genitalia. So for baby girls, we're going to look at the labia majora and the labia minora. So the labia majora may be very swollen. That is from the extra hormones that baby had gotten from mom. You may also see like a cheesy substance in the labia. That's called schmegma. That is like a cheesy sebaceous matter. And then you may also see a little bit of blood coming from baby's vagina, because that can be also induced from the hormones. It's called a pseudo menstruation. Mom's hormones inside this baby girl from delivery would cause like a pseudo period, but then that will go away. So looking again at the diaper, this is also where we would be looking for, has the baby stooled yet? Baby's first stools are called meconium. It is a very sticky black tar-like substance. It's going to be, that's the first poop, and then it's going to start changing colors from there. It gets a little more like greenish yellow. All right, next we're going to look at the umbilical cord site. So this simulation baby does not have an accurate looking umbilical cord. It's going to actually be a piece of umbilical cord that has a clip on it. That baby has been cut from mom. So we're going to assess that site for all of our RETA. So we're looking for redness, we're looking for any sort of swelling and drainage, any bleeding, any signs of infection. Those are the things that we're looking at from this umbilical cord site. The cord will start to look different as the baby gets older. Day by day, the cord is going to start to dry out and get kind of dark and scabby looking. And the cord will eventually fall off. We don't force it off. We just let it fall off naturally. And then we look at the back. So looking at baby's back, a real baby's head would turn to the side. So simulated baby. So we're looking at the curvature of the back. Do we see any sort of abnormality of the spine? This would be an opportunity to look at the buttocks and also looking at the sacral dimple. So does the baby have a dimple? Are there tufts of hair in this area? That would be an abnormal finding, and we would want to document that and report that. Are there any Mongolian spots? So sometimes babies are born with spots that resemble bruises, and it's very important that we document them as Mongolian spots, because that could get somebody in trouble if somebody would report that as bruising later. So it's really important that it's documented at birth as a Mongolian spot. So then we're going to check baby's temperature since we've had baby exposed. That would be done in the axilla. You can refer to your baby bath video if you have any questions about doing that. So we would check this temperature. If baby's temperature drops below 97.9, then we're going to have baby go skin to skin with mom. If not, and we're good, we can re-swaddle the baby up, and that would be the end of your newborn assessment. All right, I just wanted to take a moment to talk about male genitalia assessments for babies, because this could be a potential site of an abnormal assessment that would require reporting up to the pediatrician. So when we're looking at the penis and the testicles, you want to assess for where is the urinary meatus, where is the hole that the urine is coming from. It is, if it's at the tip of the penis, that is normal. But if it has been, if they've been grown to be at the top of the penis or the bottom of the penis, The top of the penis is called epispadias, and if it's below the bottom of the penis, so the shaft, it's called hypospadias. So that would be an abnormal finding. And we also want to just look at the testicles and see if both testicles have descended um, into the proper location. So that is going to be the male genitalia assessment for male babies.